Thank you, Samar. Wonderful initiation onto the instruction course. You have seen the indications of endothelial keratoplasty, which should be done, but looking into the country and number of people doing corneal surgeries, I think DMEK is being done by some people, but DSEK still remains the choice of surgery for most of us for endothelial keratoplasty because of various reasons or indications. One of the most important thing is, apart from a good case selection, the second important thing would be to prepare the graft in a manner which gives you a optimal outcome subsequently after surgery. That means the preparation should be such which gives you a good donor lenticule and maintains the endothelial integrity of that particular donor tissue so that you can acquire a good endothelium for patient and retain the clarity for a long time. Automated way of dissecting is one of the best way to dissect a donor lenticule for DSEK cases. Now you will be subsequently seeing a manual dissection also. There can be two ways of doing automated donor lenticule preparation. One can be microkeratome assisted, or it can be femtosecond laser assisted system. In microkeratome, you can have a single pass where you go to the depth, which gives you a reasonable thickness, and you can do double pass techniques also. And looking into a various system which are available, we have a Moria system which can give you a very nice regulated cuts of donor lenticule. Now we have Givor, Amadeus and Nitro, which are options we have in India also with reasonably less cost for machines. Looking to the older system of Moria, which used to have a rotatory system, which was a manual rotation, so everything dependent on your manual speed to achieve a cut. So higher the faster the speed, you used to get a thicker the lenticule in these cases. And we always require a slightly high pressure, and the bottle height should be such which gives a good maintained pressure throughout your initiation of cut in these cases. The speed of keratome, as I said, would make a difference. So if you move faster, you get a very shallow cut. You go slow, then you get a deeper cut in these cases. This is what we used to get around 200 micron tissue earlier with this. But routinely we get 9.5 to 10 millimeter cut with the microkeratome. The requirement for Indian eyes is around 7.58 millimeter tissue. So you avoid the thicker peripheral tissue by punching centrally to achieve nice equal thickness all around for these keratome cuts also. Now with a lot of expertise, we get a very thin tissue also in these situations. In our series, we have got around 50 to 80 micron thickness of tissue around 6 months, which is a very nice thickness for any endothelial keratoplasty for acquiring a good endothelial count and good results. This is one of my patients, 67 micron thickness. This is again here a 60 micron thickness. Recently we have acquired new systems. The initial system required a gas cylinder to be attached to create a vacuum. Now we have systems which are electrically run, therefore you don't require another device which takes into gas, other things. Electrical devices give you a very good cuts. You see here, this is you can see the microscope attached OCT, which is the best way to judge the thickness of a donor lenticule. If you don't have access to this, you have to do an ultrasonic thickness of donor lenticule, then select the keratome head accordingly. Thickness of lenticule is very essential to choose the appropriate head of microkeratome in these cases. So this is around 550 micron thickness of donor lenticule. We have selected 400 micron microkeratome head, electrically run state. There is no rotatory movement, therefore it gives a very nice smooth cut of donor lenticule. And you can subsequently judge what is the thickness of a donor lenticule you have achieved with the microkeratome cut. And that is possible because of attached OCT pictures you have in these patients. As you have less than 150 micron thickness, it's very difficult to measure with ultrasonic devices. So these IOCTs are very nice in that way to give you a nice assessment of a donor lenticule, pre-thickness and post-thickness also. This is a Gibor system, again electrically run system, and a hand-free system where you don't have to really use the hand for cutting these things. Gives you a very nice controlled cuts. You can have from 160 micron to 600 micron keratome heads for a controlled cutting of donor lenticule in these patients. If you want to do a very thin cut, then you have to have a double pass technique. First we go with around 350 to 250 micron cut initially, depending on our graft thickness, donor lenticule thickness, and subsequently then you can do other pass. You can see here after initial pass The thickness was around 280 to 300 micron here, which is really thick for a modern day DSEK surgeries. So we have planned 100 micron from opposite side to cut this tissue to achieve less than 60 micron cut in such cases. So you have to make sure your graft is well oriented, the thickness is well measured with your OCT imaging. Then you plan a second cut. If you have not acquired a good thickness, then you have double pass technique, very difficult in such cases. So this is around 50 micron thickness, which is the ultra thick DSEK in these cases. You can similarly do with the femtosecond assisted surgeries also, though it will be a very costly affair because you require a interface for this. So this is a 8.5 millimeter we are doing with the femtosecond cut here. You can see very nicely it's cutting here. Subsequently, you can make a side cut which will go up to the depth desired for you. This was planned for a 450 micron cut of a 560 micron thickness of donor lenticule. So if you can see, after we take it to the microkeratome, open the peripheral thing as you do for LASIK patients, then lift the entire flap. You can see how nicely flap, thin cornea. You can customize the entire thing very nicely with the femtosecond laser. This is the initial report where they compared the surface of a LASIK patient with keratome and femtosecond, and these are older generation femtosecond where keratome was better than a femtosecond. Recently, we have done studies for a DSEK lenticule preparation with femtosecond, comparing keratome versus femtosecond by doing a scanning electron microscopy and atomic force microscopy for surface assessment with the help of IIT Delhi. And this is what we acquired, electron microscopy picture of endothelial cells of both keratome and femtosecond. They were equally viable in both the groups. Similarly, for atomic force surface analysis of keratome and femtosecond laser preparation, we've got a nicely smooth surface for both the groups. But there were not statistically significant difference in both the groups. This indicates femtosecond laser can also be used for these cases. To summarize, the automated preparation is better in terms of it gives you a customizable thickness of a donor lenticule, much more predictable. Chances of tissue loss is also very, very less in these cases. You get a very nice smooth surface, and the advantage of pre-cut tissue is also there. You can send tissue to other transplant centers, also to surgeons. You can acquire ultra-thin grafts. Most importantly, these can be done in eye banking with the technicians can do very nicely this, and without requiring a surgical expertise for a surgeon in these cases, where manual dissection will require a real surgical learning and proper surgeon doing those dissection, and chances of tissue loss is also much more in a learning curve of preparation of manual dissection in these cases. Thank you for your kind listening.